Thank you for the introduction. I'd like to extend my gratitude to everyone for attending this conference. I will be discussing about RV dysfunction in patients with LVAD. I'd like to introduce two cases of LVAD patients who experienced LVAD failure. I'm outlining the approach for evaluating and management of RV failure in patients before and during LVAD implantation. We begin an evaluation 48 hours before LVAD implantation, which includes right cath and echo. And at this point, we can also optimize the patient's condition with directives and inotropics or CRLT. If CVP is less than 15 and the CVP pulmonary capillary wedge pressure ratio is below 0.6 and the PAPI is greater than 2, the patient is likely stable enough to proceed without additional intervention. However, if these criteria are not met, we proceed to clarify the level of RV dysfunction. And moderate RV dysfunction is indicated by CVP under 15 and 18, and PAPI, pulmonary artery pressure index between 1 and 2, along with the presence of additional RV dysfunction criteria. In this case, we use a durable LVAD and may consider an elective temporary LVAD. And second, RV dysfunction and severe RV dysfunction is defined by CVP greater than 18 and a PAPI less than 1. Patients with severe RV dysfunction, especially if additional criteria are present, may require more intensive support such as BiPAP, total artificial heart, or possibly heart transplantation or palliative care if other options are available. In case where acute RV failure develops during LVAD implantation, further management steps need to be taken immediately, which address in a separate pathway. In the bottom of the right slide, I listed the additional RV dysfunction criteria like organ dysfunction or by the echo, TAPSI or LVEDD and LVEDD ratio and tricuspid regurgitation. And to minimize RV failure risk in LVAD patients, several surgical and perioperative factors are crucial. Use less invasive implantation to preserve biventricular function and reduce RV stress, and prevent bleeding through meticulous technique. It depends on surgeon. And administrator protamine to aorta and consider delayed closure if needed. And additionally, optimize afterload like inhaled NO or low P or optimize mean arterial pressure. And preload like volume management and contractility with the inotropic support and arrhythmia management is essential for support RV function. And we have option for right ventricular mechanical support using the impeller device already Kato already told, and this device can be inserted with a closed test and require anticoagulation. However, they do not provide respiratory support. And unfortunately, until now, we don't have an impeller in Korea. And compared to VA ECMO and LVAD as the option for RV support, VA ECMO has challenging because such as difficulty in balancing blood flow and higher risk of complications, including mortality and limb ischemia and pneumonia. And overall, it shows increased adverse events and mortality compared to LVAD as shown in the left study. And for percutaneous LVAD cannulation, we have options suited for patients with a closed test with an oxygenator, and two independent cannulas like this, and cannulation of the pulmonary artery via the right jugular vein, or cannulation of the right atrium via the femoral vein, or double lumen cannulation like Protect Duo, which allow for easier cannulation and potentially improve patient mobility. However, in Korea, we don't have a Protect Duo. And surgical LVAD place shows the inflow cannula in the right atrium. and then via the femoral vein and the outflow cannula connect you to pulmonary artery. This setup provides robust RV support in conjunction with the LVAD, especially in case of severe biventricular failure. And I will show you this cases and CenturyMark support for RV and then LVAD case. And after LVAD placement, we have to think how to wean patients from the LVAD if possible. This is a protocol proposed by the author from Berlin. And our institution, we are more benevolent in inotropic therapy. And administrator inhaled the NO if necessary, and early extubation is very important. But there are also some potential risks on successful weaning, and so some patients need high urgency for transplantation or switch to LVAD, or some surgical techniques needs challenging, like outflow tract are more difficult to implantation. So from now on, I will show you the first CenturyMark RV support case in Korea. Actually, CenturyMark was approved last year in Korea, and so because of the insurance problem, so I will show you the first CenturyMark RV support case in Korea. As I told you, we don't have impeller or protect duo, so sometimes it's very challenging for protecting RV support. Male, 44 years old, his body status is good, and recurrent dyspnea. Initially, he was not my patients, other doctor's patients, and initially he was mildly reduced EF diagnosis and persistent AP with slow ventricular rhythm. So EP step inserted the pacemaker instead of ICD, and after that he had a subacute renal infection and IV thrombosis and dyspnea aggravation. So he was transferred to me as a advanced heart failure management. 1 year ago, his echocardiography is like that. Even though the heart rate was decreased, the LV function and RV function are a little mildly decreased, like 45%. However, after he was transferred to me, I checked his genetic study, and then I found his lamin mutation. Lamin mutation is very famous for ventricular tachycardia or ventricular fibrillation. And his LV function was decreased very, very rapidly. So after he got dyspnea, he visited to ER again, and several times administration, and ER we found cardiomegaly and then bradycardia, and then we are waiting for LVAD and then LVAD acceptance. In Korea, we need to permit to insert LVAD in patients needing LVAD. And echocardiography shows, as you can see, both ventricular failure and both atrial enlargement. It is severely decreased compared to the 1 year ago. And then we did the right catheter cath. See, the CVP under 15, no, and CVP and pulmonary capillary wedge ratio under 0.6, no. His RAP was elevated, and RV systolic pressure and diastolic pressure 64 and 8 millimeter mercury, and pressure PAPI, pulmonary artery pressure index is 1.8. So it's kind of marginal. However, I thought his pulse pressure of the RV is 64 to 8, so wide pulse pressure. So and then he's kind of young, so I thought he could be tolerable in LVAD, and also there is no sign of other organ dysfunction like renal or liver or mechanical ventilator. That was okay. However, he's a marginal patients for LVAD because the RAP was very elevated, and we've waited for acceptance of LVAD. However, it took 2 weeks, and then even though there are some non-sustained VT, he looks stable. However, at that time I prayed, oh no, he might be some sudden cardiac arrest due to refractory VT or VF before LVAD. So, but I prayed for the acceptance of the LVAD. Yeah, unfortunately, one day just before LVAD insertion, ventricular arrhythmia occurred, VT, VFib, and then BP drop, and chest pain here occurred even though amiodarone or lidocaine loading or several defibrillation, it does not recover the only VP, VT, VP, VT. So we inserted the ECMO, and at that time, systolic blood pressure was 60 millimeter mercury. And then even though ECMO insertion, the VT persists. And then see the several times of defibrillation, it can affect the RV function more deteriorated. So severe RV function and intubation, only LVAD, no, LVAD does not, only LVAD, then low blood flow, and then we might be unsuccessfully do the LVAD. So we try to do the we try to use the CentriMark as a support of right ventricle, so like this. This is the CentriMark catheter, so RA, to pulmonary artery, and this is the LVAD. And so we insert the LVAD and also LVAD and then CentriMark use, and something like that, and RA to pulmonary artery and also LVAD. So most of the time BiVAD is like this, RA insertion and then going to the blood to pulmonary artery and then LVAD, and then there is monitors. And this is the BiVAD schematic figure. So we insert LVAD plus LVAD using CentriMark. The post of 1 day, it appears decreased LVAD function more and more, and severe RV dysfunction. And see, like this. And this is LVAD flow. In the first time, the flow was 3.3, similar like LVAD. The left ventricle flow was 3.5. Then after 4 days later, at that time, I thought the reason LVAD dysfunction is because of severe defibrillation and then VT and VFib. So we've waited for 4 days, and a follow-up echo shows a recovery of RV. So see, even though the LVAD support was only 0.3, the LVAD flow was stable. So improved RV function and RV support only 0.3, and LVAD flow was 3.3. So after we saw the RV function was recovered, and then LVAD was the function was good. So we win the LVAD winning and transfer to the patient to the ward. And before discharge, we did the right case again. See, the RA pressure was significantly decreased, and also RAP was decreased, and also pulmonary artery wedge pressure was decreased, and it was very successfully did. And even though the PAPI was a little bit lower than I expect, but he's okay now, and then he's stable. And the second case I would like to show you, the LVAD case, very old patient, 76-year-old, and destination therapy for LVAD. She got MVR and TAP and major P. At that time, LV rupture and then repair. And even though optimal medical therapy, her ejection fraction was only 22%. And then she got CKD because of the cardiorenal syndrome. And she admitted several times due to dyspnea. We are very cautious about her age, and also she is very lean and fat and very frail. And however, her ejection fraction was very low, and she would like to do some more things because of the dyspnea. And then one day, azotemia occurred, so we did a CRLT. And then with the CRLT with volume control, see, her LV function was very, very decreased, and also RV function was decreased. So, but the RV right case shows the RV pulse pressure was widened, and then PAPI was 2.8. So I thought she could be endured LVAD without RV support. So we inserted LVAD without RV support, and then we gradually the pump flow increased, and then very low pump flow like 3.0. And at that time she was really good, and then cardiac rehabilitation and diuretics and optimal medical therapy. But 1 month later, dyspnea again, it is due to the LV, the flow was lower, relatively lower, and pulmonary hypertension. So we increased the RPM and the flow gradually. So now the pump flow is 4.2, even though the pump flow was optimal, the RV function was good. So we did gradually raise the RPM. So in the summary, I would like to talk to you. The evaluation and optimization is really important. Pre-implantation assessment of RV function and hemodynamic optimization are essential to minimize the risk of RV failure in patients with LVAD. However, despite best efforts, acute right heart failure may still occur, so we have to prepare. And also risk stratification. We clarify RV dysfunction as moderate to severe based on hemodynamic parameters, guide our choice for support strategies. And also mechanical support we need. But in Korea, unfortunately, ProteQ and Impel are not available in Korea, but someday it should be imported. And each has unique benefit and risk tailored to the patient's need and procedural context. Thank you for your attention.